Hi everybody, welcome to my channel. Today we'll be discussing December 2021 DNB question paper 1. Coming to the 10th question, they have asked about elaborate radiographic features of Cleidocranial dysplasia and rickets. For each they gave 5 points. So total 10 marks. So first coming to cleidocranial dysplasia. Cleidocranial dysplasia, what is cleidocranial dysplasia? It's an autosomal dominant condition. There will be mutation in chromosome 6. What happens in this? There will be faulty ossification of intramembranous and enchondral bones. There are two types of ossification, intramembranous and enchondral ossification. What happens here? So this doesn't happen. There will be faulty ossification of intramembranous and enchondral bones. Directly going into radiological features, first we'll talk about skull. What happens in skull? If you take this as a skull, in this what happens in skull? Here there will be early in infancy, there will be delayed or absent ossification of calvaria. As a baby grows, there should be ossification of the bones of the calvaria, and there should be closure of the frontal layer. Here what happens? There will be delayed ossification or absent ossification of the calvaria. Then these are the sutures. We have coronal suture, parietal suture, and lambdoid suture. With time there will be multiple intrasutural bones. These intrasutural bones are called as Vermean bones. There will be Vermean bones formed in the sutures, and often metopic suture will be present. Here metopic suture persists. There will be widening of the coronal suture and there will be widening of the sagittal suture. It gives an hot cross burns appearance. So again there will be widening of the interparietal diameter causing marked brachycephalic. The supraorbital region, temporal squamous region, occipital bone will be frequently thickened. Coming to foramen magnum, the foramen magnum will be deformed, enlarged, and there will be platybasia. Then due to underdeveloped facial bone, there will be small face, and frequently the nasal bone they fails to ossify, and PNS are hypoplastic in these patients. Although the maxilla is small, the mandible is large, and the mandibular suture closes very late. A high arched or cleft palate is not uncommon. There will be delayed and defective dentition as a prominent, often symptomatic finding. Dental panoramic radiography is required. So these people, they can present with dental problems, dental caries, defective dentition will be there. Small face will be there, mandible will be prominent. Foramen magnum will be deformed, enlarged. And intervermian bones will be there, intrasutural bones will be there. So these are what some of the skull radiological features. Coming to thorax. So most common feature which will be given for spotter is the clavicle, absent clavicle. Coming to, there will be 3 separate ossification centers for clavicle. One is sternal end, middle, and acromial. So one or more of these centers may be affected. There is considerable variation in clavicular involvement. Sternal end might be involved, middle end might be involved, acromial end might be involved. Patient can approximate both his shoulders under the chin. These are all clinical features. So coming to radiograph, in viva or spotters, they may keep this x-ray where 10% of case you will not be seeing the clavicle. So one of the DD is cleidocranial dysplasia. Only in 10% of cases the whole clavicle will be absent. Rest of the cases where the sternal end or middle part or acromial portion will be absent. So suppose the middle part of the clavicle is absent, pseudoarthrosis may develop. Apart from this, look at the scapula. Scapula will be small, winged, or elevated. Shoulder cradle abnormalities will be there. They allow great mobility of the shoulder. Ribs usually normal, chest narrow and cone shaped. Narrow cone shaped chest will be there. Clavicle abnormalities will be there. Coming to pelvis. This is also one of the DD. They may ask you, they may keep in the spotter also. See the pubic symphysis, there will be like midline defect will be there where the rami they fail to approximate. So midline diastasis of the pubic symphysis will be there. Midline diastasis of pubic symphysis will be there. Normally in this the pelvis will be underdeveloped pelvic bones. Then due to weight bearing, early coxa valgus develops into coxa varus. They'll have coxa vara. Then coming to femoral head, it gives an unusual shape. They're like chef hat appearance. Then there will be lateral notching of capital femoral epiphysis. These are some of the pelvic findings. There will be bilateral symmetric coxa vara. Then coming to spine. Spine, what happens? They'll have biconvex vertebral bodies. This looks something like a chocolate. Vertebra often show delayed mineralization. Biconvex vertebral bodies, they'll have spina bifida occulta, especially cervical and upper thoracic segments. Increased incidence of spondylolysis will be there, like pars interarticularis defects will be there. They'll have scoliosis, they'll have kyphosis, they'll have lordosis. And these are mainly secondary to neural arch defects and hemivertebra. So they may give like a long case or short case where they give multiple x-rays. Chest x-ray, look for the clavicle. And pelvic x-ray, pubic diastasis, coxa vara, and how the femoral head is present. In spine, what do you see? Look for spinal bifida occulta, how is the vertebral bodies. And in skull x-rays, look for the Vermean bones. Coming to extremities. Normally what happens in this, accessory epiphysis for the base of the second metacarpal occurs, creating an enlarged digit. Normally distal phalanx or hypoplastic and often pointed. They may be found even in the feet, but less common. Long tubular bones are less frequently involved, but occasionally shortening of the radius with an abnormal wrist articulation is seen. So most important, look at the distal phalanx. It is hypoplastic and tapered. Then coming to complications. Obviously, there will be hearing loss, severe dental problems, dislocations of the shoulder and hip, scoliosis. They are troublesome, but they does not affect the lifespan. So what happens if the baby or infants have faulty, like if the child has faulty dentition, dental caries, so we have to go and consult the doctor. If they are untreated, they may go into osteomyelitis of maxillar mandible is possible. Narrow thorax will be there in childhood, may lead to respiratory distress. Although unusual, platyplegia and basilar impression may crowd the brainstem and upper cervical spinal cord. And this is about cleidocranial dysplasia. Then coming to second question, that is rickets. The next topic is rickets. It's like systemic disease of infant and young children. Suppose if you get vitamin D deficiency, this is due to vitamin D deficiency. If it occurs in adults, it's called as osteomalacia. So electrolyte imbalance will be there, which involves the calcium and phosphate. They present with muscle tetany, pain. These two are the most common. Other symptoms are like irritability, weakness, delayed development, small stature, and bone deformities. Coming to clinical findings. Before going to clinical findings, what is this pathology? Normally, if you take the growth plate, most of the changes occur at the physis. There is a growth plate. We have resting zone, proliferative zone, and hypertrophic zone. Normally what happens here, we have something like hypertrophic chondrocytes. In normal people without vitamin D deficiency, this hypertrophic chondrocyte should go off, like due to apoptosis. So what happens in people with rickets, this hypertrophic chondrocytes, they are not resorbed, they will be present, they will not go off due to defective apoptosis. Due to this cartilage tissue, there will be cartilage tissue gets accumulated. There will be like this growth plate will be occupied by enlarged masses of overgrown cartilage. So overgrown cartilage leading to widening of this region. So what happens, this cartilage tissue, it's not mineralized even. So there will be unmineralized deformed osteoid tissue which accumulates here and leading to growth plate widening. So coming to symptoms, we have something like soft tissue swellings will be there around the growth plates owing to hypertrophied cartilage, I told you. Then we have multiple costochondral bumps at anterior ends of the ribs where it articulates with the cartilages, costochondral region. We have bumps that's called as rachitic rosary. That is the expansion of the anterior rib ends as the costochondral junctions. As I told, calcification, mineralization of the osteoid tissue will not be there. Uncalcified osteoid will be more. This lack of mineral content produces generalized radiolucency in the bones, and growth plate, cartilage cells at the physis grow normally but fail to calcify and degenerate. Growth plate, normally it is occupied by enlarged masses of overgrown cartilage leading to widening of the region. So lack of osteoid mineralization, the metaphyseal zone of provisional calcification will also be absent. Normally what happens, there is something like some metaphyseal, this is epiphysis, this is metaphysis, this is diaphysis. They have something like zone of provisional calcification. This will not be present in, this is normal. In normal people it will be like this, metaphyseal zone of provisional calcification, and in people with rickets this will not be present. So this is suppose if it reappears, this is the first sign of healing, if this opaque line reappears. Coming to radiological features, generally if you take an x-ray, especially the wrist joint, knee joint, all bones will appear more radiolucent with coarsened trabecular pattern. Why radiolucent? As I told, uncalcified mineralization will not be there to the osteoid tissue, so that all the bones, they appear radiolucent with coarse trabecular pattern. Coming to growth plate region, you have to know three features. First you have to know the definition of three, like fraying. What is fraying? What is splaying? What is cupping? Fraying is something like indistinct margins of the metaphysis. This is fraying, indistinct margins of the metaphysis. This is fraying. Cupping, this concavity of the metaphysis is cupping. Then splaying, widening of the metaphyseal end. This is splaying. So three features. Here we have epiphysis, metaphysis, diaphysis, growth plate. What happens to this? There will be widening of the growth plate. I told widening of the growth plate. There will be irregular, frayed. This is like paintbrush appearance. Frayed and cupped metaphyseal margin. This is called paintbrush appearance. Something like paintbrush appearance. So this is called fraying, cupping, splaying. Splaying is something like widening of the metaphysis. So deficiency of normal mineralization is most evident at the metaphyseal zones of provisional calcification, where there is an excess of non-mineralized osteoid, resulting in growth plate widening and abnormal configuration of the metaphysis. Then coming to other features, no distinct white line of zone of provisional calcification is visible. As I told, in normal people there will be radio-opaque line of white line of zone of provisional calcification. In rickets it will not be visible. This line reappears on healing, indicator of good therapeutic response. Then we have epiphysis is also frayed at the border. Sometimes epiphysis is also frayed. Epiphysis also will be frayed at the borders. There will be bowing deformities, fractures, decrease in bone length, scoliosis and pseudofracture. Then we have bulbous enlargement of the costochondral junction, that is called rachitic rosary, can be seen adjacent to cupped anterior ribbons. So we have, what is this? Here we have sternum. This is the anterior end of the rib. Here we have sternum. This is the anterior end of the rib. Here we have cartilage. This costochondral junction. This is the costochondral junction. This is the sternum. We have cartilage, anterior end of the rib, costochondral junction. This ends, there will be bulbous enlargement. Bulbous enlargement of the costochondral junction is called rachitic rosary, can be seen adjacent to the cupped anterior ribbons, which can indent this one, then can indent the pleural interface or even the thymic shadow. Then coming to bow legs. Once the child starts walking, due to weak bones, bowing appears. Bowing. Legs bow outwards with the variable deformity of the hips. Both coxa vara and coxa verba are seen. Genu valga and vara, protrusio astrobila are also noted. The lower ribs may also be drawn inwards inferiorly by the attachment of the diaphragm. This is called Harrison sulcus. Treatment will be there, but radiographic features take still 2 weeks time. So the rickets lag behind biochemical and clinical improvement by about 2 weeks. Harrison growth arrest lines is a dense line traversing they will be parallel to the metaphysis. It can be used as a marker of old rickets. Patient had rickets, treatment has been given. After a few years, if you see, there will be like this growth arrest lines. So it's a marker of old rickets. So this is about rickets. Thank you.